your mic. Thank you.
Good afternoon, everyone. Welcome to November 20 Finance Committee meeting of the board. Would like to kindly ask Dr. Nettles to remind us the mission statement and the vision.
Gladly. Mission statement: to improve the health and wellness of Nashville by providing equitable access to coordinated patient-centered care, supporting tomorrow's caregivers, and translating science into clinical practice. And the vision is leader in exceptional community health care, one neighbor at a time.
Thank you, Dr. Nettles. And we'll go over the conflict of interest. This is the opportunity for any member to disclose a potential conflict of interest. That way they can be unbiased, or they can elect to recuse themselves. All right. Seeing none, we'll move to any public comment.
No, sir, there are none.
Okay. So the minutes of our October 30th meeting were already sent by email. Do I hear a second?
Second.
Any discussion? All in favor say aye.
Aye.
Any opposed? Minutes are approved. And we go over to financial year 25 audit update. Dr. Kimberly Blackledge.
Good afternoon. Thank you, Mr. Chair. I'll move forward to speak about the current state of the audit. On last Friday, November the 14th, we submitted the financial statements with notes. And to be clear, what that includes is management discussion and analysis, probably about 12 pages or so, our basic financial statements, our supplemental information, which includes schedules, and then other ancillary documents as needed. Probably about 46, 48 pages were submitted to Metro to be included in their other documentation or support, and it was submitted as draft. A copy was also delivered to Crossland. Crossland will then intake that and continue to finalize their audit. As of today, I believe, or yesterday afternoon, the 19th, we received probably about 10 items at the request of our auditors, Crossland, so we are continuing to work with them. I know that 3 are complete. Another 3 probably by the end of the day will be complete, and then we're working on the remaining 4 items. Happy to take questions, but there were probably greater than 200 data elements that we submitted over a SureLink confidential, secure space, and we have been moving with our audit. As I do close, if there are no questions, I will share we have recommendations for our audit process for next year that we will be bringing forward to Crossland and to Metro Finance, whoever is involved. Any questions? Okay.
Thank you, Dr. Blackledge. So we'll move over to contracts, capital expenditure requests. First one is the AMN Leadership Solution.
Yes, thank you, Dr. Nzarue. This is a contract for an executive search firm, AMN Leadership Solutions. To remind the committee, this is prompted by the board and the CEO search committee's desire to engage a search firm to assist with the process of appointing a new chief executive officer. We had a very strong response to the public request for proposal process. We had 10 different companies who submitted bids, several of them very strong. There was an evaluation committee that I sat on, but was mostly hospital leadership that evaluated the merits of those proposals, did scoring as a result of that scoring process, and as a result of the cost that were submitted by each of the bidders. All of that factored into a total score, and AMN Leadership Solutions scored the highest of all of the proposers. So they were tentatively awarded the contract that has since been confirmed through the RFP process and is now ready for board approval. The broad contours of the contract are that it is for a 5-year term. So the first executive search that we will use this contract for will be for the CEO position, but AMN under the contract will remain in place if we need other executive level searches. This is a firm that specializes in healthcare executive searches, and so they are a good resource if we need them, and their contract will be available for use. I should also say that the hospital has worked with AMN in the past before this RFP, and so we're familiar with them. We've had a good experience with them. Even though the RFP process resulted in a contract with them who we've done business with in the past, I think it was a very useful exercise. It's a good practice for as long as we had not put this out to bid to go out to the market and see what competitors there are and what the landscape is. And so overall, very favorable. So it's a 5-year term. The price term is 29% of the baseline salary of the executive whose position is being recruited. In terms of the bidders, that was not the least expensive bid, and it was not the most expensive bid. It was somewhere in the middle. So it seems to be within line of what the industry does. And what you have is a template agreement, which is almost ready to have sort of all the I's and T's done. There are some insurance requirements that AMN is submitting to Metro for verification. There are attachments that you'll see in this template contract for the pricing schedule and for the RFP documents, which determine what the scope and services are that were being bid. So that is to be finalized, and the contract is ready for board approval.
I have a question.
Yes.
You mentioned that we had worked with them before.
Yes.
When did we work with them before?
They had been used for a number of executive level searches, including the search that led to Dr. Webb being hired as the former CEO, but many other executive level positions, both permanent and, as I understand it, they were used to fill temporary needs. So in some instances, when there's an executive level position where we had an interim need for a 3-month, 6-month placement, they also do that kind of work.
But they were the firm that was used for the last CEO.
They were, yes.
Okay.
Just to add to that discussion, that was what led to the RFP. And there were, about 10?
There were 10 bidders.
Extensive, and you have to look at all the criteria and what they do and the scope and the brevity of what happens. So this was really a very thoroughly vetted process, which I thought was quite impressive. And Mr. Escobar was sitting on the committee in that process to at least the observation, I would say observatory, but these are the data that best represented what we needed in scope. So very good question. I had the same thing. I had the same question.
Yeah, I mean, the concern about, whether the search firm, given some of the circumstances surrounding Dr. Webb's departure, we might go back. We have to say it was 10 years ago that search took place. I don't, it's the search firm assists us. It's ultimately the board's decision as to who to hire. And based on their experience, which is extensive, and based on the materials and the approach that they have, which I will say, I was particularly impressed with their commitment at the front end to do a very substantial community engagement, and hospital staff and hospital board and Meharry and all the relevant stakeholders that are really important to the hospital. Their plan includes a significant outreach so that we have a really wide set of information and perspectives and input, so that it's not just this board and not just the hospital, but all of our stakeholders are going to have some help in helping us figure out what are the qualities that we are looking for in a CEO, what are the skills that are going to be needed to do the things that are on the immediate and long-term horizon for the hospital. So I think their plan is right, and it was reflected in the committee's consideration of the different proposals, and ultimately, all of them were scored, and their score for theirs relative to of the others was impressive.
Well, I'd like to make a motion that we recommend this recommendation to the board.
Second.
All in favor, say aye.
Aye.
Any opposed? Motion carries. The second item is Advanced Sterilization Product Services. Dr. Joshua Baxter.
Good evening, Mr. Chair and board members. The contract before you is for advanced sterilization procedure. This will be a new sterilizer for our sterilizing process department. The reason we are requesting it is our current sterilizer is end of life and cannot be repaired, as the letter in there from the company states. This was the only vendor that was vetted because this is specific for that area and would be compatible with our other equipment. Initially, we had a price of $275,000. We got that down to $208,000, and with some negotiations, we were able to get that to $133,000. That does include a 1-year warranty, and included in the cost is a 2nd-year maintenance agreement for the total price. I'm open to any questions.
Mr. Chair, I make a motion that we accept this proposal.
Do I hear a second?
Second.
Any discussion? All in favor, say aye.
Aye.
Any opposed? Motion carries. Then we're up to, we're going to skip item C because it's not up for approval, and go to D, Southwest Communications, CR Jerry Gallo, Director of Facilities.
Good afternoon. This is part of the larger capital plan that was approved earlier in the year, and it is to replace approximately 109 analog cameras and wiring with new digital cameras. The project itself, because of the software we use, is proprietary, so it could not go out to bid. You're assigned your local vendor. Is there any?
And why was this not in the capital budget?
We've had over the years in previous, this is in the capital plan that was approved.
Okay.
So it is capital.
Okay.
Yes.
Well, I thought we said
We have
that-
funding for it.
Yeah, we have funding for this. Originally, I'll say, originally around, I want to say the August board meeting, we submitted a kind of urgent capital needs to the board. It's $2.1 in the bank. Because of the bylaws, we need.
Thank you.
So this system, what happens, what's the lifespan of this system?
The cameras themselves they could be 5 to 10 years. I mean, useful life is probably about 5 to 7 years max. It's an electronic component. What we have now is analog, which has obviously been there for years.
So I think that my concern is that if in the next year and a half, we begin to talk about a new facility, then what happens with this particular investment? Can it be moved over? Can it be repurposed? I think that as we are discussing upgrades, they should be in consideration with a new facility that we sorely need.
To answer your question, you can repurpose these. So you can take these, but in 5 to 7 years, you might be looking to replace them anyway. But you could take some. You're not going to be able to just take these and move them to the new building, because the new building, before you leave here, needs them in place. So yes, they could be repurposed to other places. Like I says, if you looked at the quality of the images and how often cameras go down, is the reason we're replacing these.
Understood.
Okay, yeah.
Well, just one caveat, if I may, for the board's edification, is if we did get a new facility, we still have to leave this emergency department open for 6 months, past the opening of the other. And so there will be some things that we will have to duplicate, and some investments that we make right now in enhancing this building that can immediately go, as Jerry had just verbalized. But the emergency department would have to remain in place for 6 months after the opening of the new facility.
And a quick question on the cameras. Just the use of the cameras, are these for security, or are these for, can you describe?
They are security cameras.
Okay.
That is their only purpose.
And are we increasing the number comparatively? Obviously, the technology is, so it's the same.
It's a one-for-one swap.
Just out of curiosity, would there, in a perfect world, be an opportunity or a need to increase the number of cameras and or security measures that we do have in place? The question is, is this something that we need to consider looking at and evaluating going forward?
So there was a security analysis that was completed on this building, and some of the things that we have asked for several years on the capital list was a result of that security analysis. The cameras is one, also visitor management system as well, metal detector in front of the emergency department, which, as you all know, as you visit other emergency departments, they have that. And so these security upgrades were part of that security plan and analysis. And so these are kind of our minimum, like, urgent needs, which is why we asked for them urgently. And they are in that $2.1 million that is already funded.
Make a motion that we accept this proposal.
Second.
Any further discussion? All in favor, say aye.
Aye.
Any opposed? Motion carries. And then we get to CFED, Mr. Rick Pence, Lab Director.
Good afternoon. I'm Rick Pence. For those of you who don't know me, I'm the director of the clinical laboratory.
The reason for this request is for the Cepheid, the Gene Expert. It's a molecular infectious disease instrument used in microbiology. And this was going to bring in 3 high-volume critical tests that are currently sent out to a reference lab. And the turnaround time for the reference lab tests take 2 to 6 days. And these testing we bring in-house will be resolved in about 90 minutes. This is a 3-year lease. The cost for send-outs last year for these tests were $188,000. The cost to bring in this instrument, including reagents and everything, is about $2,800 less than the cost of sending it out. And let's see. And this includes a 3-year maintenance service agreement with the instrument.
I guess in the spirit of where we've been going with conversation, is this equipment movable?
Yes.
Okay.
Yeah. Yes, it is. It's it's a big box. But yes, sir.
Is the use of the equipment something that is billable? In other words, what we're doing now is we're sending it to another lab.
Yes.
And so is this, what's the revenue implication of no longer sending it out and now in-house using having our own lab facility?
The key is the turnaround time for these tests, because a lot of these tests are culture-based where you have to grow bugs, and you've got tests like your MRSA test. It takes 2 to 3 days for turnaround times. This instrument will give it to you in less than 90 minutes, and that does affect the antimicrobial stewardship and everything. TB is another test that we would be bringing in-house. That test can take up to 6-7 days, and during that time, the patient is waiting on getting like 3 sputums in a 24-hour period, and they're taking up 5 days, 6 days length of stay. This is the only piece of equipment that's approved by the CDC. If you get that first test that's negative, you can discharge the patient immediately.
So I guess my question is, say that the patient who is receiving the MRSA test has TennCare, and we perform this test. Mm-hmm. Is that a separately billable event that then gets submitted? Or is
no? It's a regular bill, like just a regular lab test. It doesn't matter, Medicare, Medicaid, whatever.
Okay. Do you see what I'm asking?
For inpatient care, it's typically DRG related, and so it's a bundle payment.
So, Mr. Escobar, to answer your question,
yes.
It's cost deferred. So if we have to have the patient get the 3 sputums,
yes.
That means those are the days that they're here. But if we cut it down to 1 and we can discharge that patient, then we're not billed that extra 2 days that the patient would have stayed. So to answer your question, it's cost deferred.
Yeah, perfect, great, thank you. I mean, it sounds like a great upgrade for patient care, which is fantastic, and also just trying to understand whether there is some, what the financial, but I understand if it's DRG and it's bundled, then I understand.
I saw that there was it says on describe the nature and scope of services. It says the cost savings annual will be approximately $650,000.
Yeah, that includes especially focused on the TB test, where as far as the length of stay, the nursing labor, the PPE, and based upon our last 2 years' volume, that's kind of what the average was. And that was not just for that cost; that was included in all 4 of the tests we'll be bringing in-house.
And that's $650 that we will now receive because of having this.
Correct.
Okay, thank you.
Well, I'd like to make a motion.
Second.
Any further discussion? All in favor, say aye.
Aye.
Any opposed? All right, the last one is Beckman Coulter.
Okay. The reason this request is for a replacement for our current chemistry system. Chemistry systems performs probably 60-70% of our total lab testing in-house here. And we've had this instrument going on 10 years, and there's only a handful of them across the country right now. The average operational use for them is around 6 years, and has been obsolete and it has been sunsetted. So our current system right now is, it breaks down pretty much daily. It definitely needs to be replaced. This contract, it's a 5-year contract. Included is a 5-year service agreement in that. And our current cost that we paid last year is $632,000, which includes reagents and everything. And I got the brand new instrument for the cost neutral.
Any questions?
Rick, does this include a link to Cerner? How does it interface?
Yeah, it's linked to Cerner, and I negotiated, got a $40,000 IT allowance for them to connect it up to Cerner. Yes, ma'am.
Do I hear a second?
Second.
Any further discussion? All in favor, say aye. Aye. Any opposed? Motion carries. Now we'll move to October financial statements. Dr. Plattridge.
Thank you, Chair. We will proceed with sharing the October financial statements. Rick Mercado will cover the notes and the income statement, and then we'll move to.
Okay, hi everyone. I'm going to start with the income statement summary. Starting with revenue. Revenue was $2 million less than budget. That breaks down into outpatient revenue, which exceeded budget by $2.5 million, offset by inpatient revenue, which was down $4.5 million. And that came from two primary areas. One, there was a $2.2 million reduction to inpatient revenue as part of an adjustment related to a prior month accrual. And then volume was below expectations. Admissions, for example, was average 225 July through September, and in October it decreased to 188, or a 16.4% decrease. Also, patient days, which averaged 906 July through September, decreased to 763 in October, or a 15.8% decrease. Expenses, total expenses were $14.1 million, which were $979,000 over budget. Total expenses decreased from $14.4 million in September to $14.1 in October. Salaries, daily average of $175,000 stayed consistent from September. Also, pharmacy continued the trend of exceeding budgeted expenses by approximately $265,000. On the next sheet, on balance sheet summary, the major item there was cash decreasing from $13 million to $6.9 million, as expected, to fund operations and to continue paying down the backlog of accounts payable. And just one item to point out on the stats, which is the next slide. Clinic visits, right, a little bit lower than in middle of the page down. You can see, of course, this relates to outpatient revenue. You can see in the current month, 5,136 on a budget of 4,656, or 10.3% over budget. And all on the far right, you can see 19,486 year-to-date clinic visits on a budget of 18,473. So just pointing out outpatient revenue. Any questions on the financials, income statement, or balance sheet?
I have a question on the income statement, just to see what we can expect through the rest of the fiscal year, whether there's a significant difference in additional state funding under revenue from $7 million to $14.3 million. And it's, you know, our net income, you know, we're about $7 million over, which is interesting to me that's what. Sure. I read that to account that additional state funding is a significant driver in being significantly ahead for net income is where we would expect to be right now. Is at some point in the future, are there going to be expenses that are going to offset that significant difference in revenue, or can we expect that $7 million sort of cushion from the additional funding on revenue to continue to hold?
I think it ideally would be. Unfortunately, we've had to carry forward a lot of old aged AP that was not part of the budget for this year that was incurred last year. So that's where a lot of that, most of those funds have gone to that in funding regular operations or payroll.
Any idea as to like how much that old accounts payable is going to affect that? In other words, I mean, it would seem like now we're in a financial position that if we maintain to our expenses and the other revenue stays as we expect through the end of the fiscal year, we will be in a really good financial position at the end of the fiscal year. So if the expenses are going to increase above what we have budgeted so far because of accounts payable, like how much of a hit do we think that is going to be over the course of the fiscal year?
Yeah, that's a great question, and we've actually recently looked at this, the forecast for the rest of this year, calendar year, as well as the fiscal year, and we do anticipate being in much better shape as we go through the rest of this year with additional funding that's coming, the growth market strategies that we have in place, and cost reductions. So we certainly do. We've chopped down that old AP, which we rightfully celebrated last month, and we continue to do that and have that focus.
All right. And thank you, Ray. And I will add a few data points. One is we came into this new fiscal year with old aged AP probably to the tune of probably $14 million, I think. And I know we immediately paid out $6.5 million. So when you think about the carryover and what that looks like, that's just me sharing a little bit of that background. Second to that, you ask about the financial. Well, let me talk about AP a little bit. So that's a little portion of the old AP. We still have AP challenges today. We are in a position where we currently pay out our 30 days, and everything greater than that, we pay on it until we're able to pay it out. But we do have a plan. Our plan, which we need to defer until the first of the year because we're not in a position, we've had audit, we've had other things, but we do have a plan that we are actively working on and closing it out to be able to share some parts and pieces of it. But with that plan, it is to pay down all of everything that's greater, and we do see that we will, we believe in success, and we believe that we'll be successful based on the path that we are on now and paying down our AP. We've worked with a number of vendors. There's a lot of information that literally don't make it here, but negotiating, actually terminating, we've talked a little bit about that, and then saying we are not in a position to pay, being candidly honest. And so we have had those conversations with our community members, with our vendors and others. But we look forward to sharing more, but we're in the best position that we could be in today, considering the situation for which we closed this most recent last year's end. So we're in the best position we could be in right now.
Great, thank you.
Can I just give some kudos to Dr. Blackledge and her team? Many of you know Dr. Blackledge took over in February, and in February we've shown a couple of times on the screen we were at negative 14 million in February at that time, and all the work that has been done through the finance department as well as the leadership team in controlling our expenses and paying down that AP. I just think, again, they should be applauded, as well as the leadership team here at Nashville General Hospital for all the work that's been done to correct a wrong situation.
Any other questions? Okay.
Motion to approve the October financial statement.
Make a motion, we approve the October financial statement.
No.
Second.
Any further discussion? All in favor, say aye.
Aye.
Any opposed? Motion carries. Thank you, Doug.
Keep going.
Then we go to the revenue cycle. Dr. Blackledge.
Thank you, Mr. Chair. So let's talk about the revenue cycle and all-in cash as it relates to a percentage of net revenue. We closed the month of October at about 4.4 million, if I round it off, which was 134%. And so, as you can see, and that's for the month of October, but you can see the cash is continuing to trend upward. You can also see that our year-to-date average over a period of time of 2025 is at 99.8, and then a 12-month average is at 99%. And keep in mind, January and February are months where we had some significant challenges which were expected due to the conversion. So that's the good note. Cash continues to be positive and trend positive. As it relates to the unbilled activity, we had a challenge internally with some recurring accounts. And so those recurring accounts, meaning that for patients that come in and visit with us and they have physical therapy, oncology services where they are here once or twice a week for some period of time, 30 days, 45 days, we release those all at the end of the month. And so what you see in the October piece is the movement of those accounts moving through there, not as quickly or swiftly as we needed them to move during that time. So we have some processes under review as it relates to the unbilled piece of it. As it relates to denials, so denials, the month of October, we have a huge spike, or what I would call a significant spike. We closed the month of October in terms of denials at 987,000. We had one account with Oscar Health Plan for $600,000 that was denied. It does not mean that we're not going to receive payment for it, but it does mean at this point in time it's what I call a slowdown in our cash. So there's not acceleration right there. The account has been appealed. It's related to a readmission. So there were two different episodes of care combined, then resubmitted to the insurance provider. And so that accounts for about 2/3 of the $900,000 there. And our goal is to get paid from Oscar and everybody else. Happy to take any questions that are needed or share further information.
You got a motion to approve the revenue cycle report?
Second.
All in favor, say aye. Any opposed? Motion carries. And, at this point, we get a motion to adjourn. All in favor, say aye. So we're adjourned. Thank you, everybody.